Morning, everyone. Thank you for joining us on National Cancer CNS Day for this webinar about the role of some of our cancer clinical nurse specialists. I'm Louise Edwards. Do you want to pop it on the next slide, Nia, actually? Thank you. So I'm Louise Edwards. I'm the head of nursing for cancer. I oversee approximately 30 cancer clinical nurse specialists in the trust, covering 10 tumour sites. So we cover gynae, haematology, cancer of unknown primary, upper GI, colorectal, head and neck cancers, lung, breast, urology and skin cancers. Some of these nurses also cover the acute oncology service and also our systemic anti-cancer therapies, so our chemos and other cancer treatments. In addition to this, we do also have paediatric cancer clinical nurse specialists working at the trust as well to support the paediatric patients and their families. So I've got Jo Kellaway here with me. She's the colorectal cancer clinical nurse specialist, one of them. We've got 3 in total. And she's going to do the webinar and talk to you a bit about the role of our cancer clinical nurse specialist. So I'm going to hand over to Jo.
Thanks, Louise. Can I have the next slide, please? So I'm just going to talk to you a little bit today about our role and how we support patients with cancer from diagnosis through treatments and to living with and beyond cancer. Next slide, please. So having a diagnosis turns people's lives upside down often, even though some patients are actually relieved to finally know perhaps what is causing their symptoms. Research has actually proven that many patients hear very little after the word cancer has been used. Our role as CNSs is very much to support patients and families at the diagnosis stage. We will try to meet our patients potentially at their very first investigation. So in colorectal cancer, we often go down to the endoscopy unit and meet patients. At that point, we just give them our contact card, and obviously it's nice for them to have a face and they get our telephone number so they know where to go, and we explain the process that will happen thereafter. Next slide, please. So at the beginning, patients do get an awful lot of information and tend to get a little bit overloaded with everything. They have lots of appointments and are suddenly thrown into the hospital system, which actually can be quite alien for a lot of patients. We all take it for granted, those of us that work in a hospital setting, but actually it's a pretty scary place for a lot of people. I often compare it to perhaps when I go to an airport, that's quite an alien experience for me. So I think we try to keep this in our mind. Our role is very much to be the link person, to help and reassure the patient and just help explain a little bit about procedures and systems within a hospital setting. Next slide, please. So as CNSs, we have an in-depth knowledge of our tumour area and can explain how and why decisions are made. We also play a key part in our multidisciplinary team meetings that all tumour sites have. And we will often lead cases in the MDT just so that efficient treatment plans can be made. Next slide, please. As CNSs, we're in an ideal position to assess patients holistically. We actually use a tool by Macmillan that helps to identify patients' concerns, including physical, practical, emotional, spiritual, and social needs. Once we've done this assessment, it then gives us a good basis to put in referrals when patients need extra support. That can include things like financial support. We use the Citizens Advice Bureau that's funded through Macmillan. It may be that some patients require extra psychological support, or it may be that patients want access to health and wellbeing groups. But that initial assessment helps us to do those signposting to various other places. Next slide, please. Communication. So communication for me is key really as a CNS. I really believe that lots of things can be sorted out through communication. For patients not knowing and worrying, it can be such a horrible time for them. So having someone that they can email or pick up the telephone to is hugely important, just to help us explain to them what's going on. In my experience, even if we don't know the answers, but we tell a patient we're going to try and find out the answer for them, they're generally very happy to accept that somebody is trying to sort something out for them. As CNSs, most of us have done the advanced communications course, and we also do level 2 psychological support training, just to all enhance our patients' experience. Next slide, please. So we act as the patient's key worker, and part of our role hugely actually now is liaising with the wider team. So as cancer treatments have evolved, we now refer patients for lots of new types of treatments in other hospitals. So for us from Harlow, a lot of our referrals go to our London hospitals for radiotherapy, for more advanced surgeries, and for sort of clinical trials, some clinical trials that may not be done here locally. We also in colorectal, we refer to as far away as Basingstoke as well. So we do spend a lot of time liaising with partner teams. Luckily, we don't have to use bikes or buses to do it nowadays with technology. Next slide, please. Although it's a bit of a cliche, cancer is a journey. I feel that is a true statement. There can be lots of hiccups along the way for patients. And although as CNSs, we may not be able to prevent them or solve them, but our role certainly involves supporting patients and families if things don't go quite according to plan. For example, surgical patients can get post-op complications that can delay their recovery. Patients on chemotherapy and immunotherapy can become septic and get blood clots. And unfortunately, we do get patients that will have disease progressions when they're on treatments. So a big part of our role also involves liaising with our teams within our trust. So we liaise with our ward teams, with our acute oncology service who support cancer patients that are admitted, and our palliative care team. As CNSs, we do use a tool called the UCONS tool, which is a triage tool for patients that are on chemotherapy and immunotherapy. It just helps us to assess patients over the telephone and then look at the best options, whether they need admitting or if we can work out another way to help them when they're unwell. Next slide, please. As the CNS, we also need skills to manage our survivors. So, you know, part of our role is to help patients return to a normal life after cancer treatments. Most patients will go on to some form of a surveillance programme. In colorectal cancer, our surveillance programme is actually a 5-year programme. We are lucky in our tumour site in that we have a community CNS who provides an end of treatment clinic for patients, whereby she gives patients sort of a detailed plan of their treatment called a treatment summary. She also gives them signs and symptoms to look out for, and she goes over the surveillance programme in detail, explaining when they'll need blood tests, scans and colonoscopies. I know other tumour sites are also hoping to roll out this service. Our role does also involve facilitating end-of-life care sometimes. That may mean that we need to do a hospice referral, liaise with our community teams, including the GP, and we may also need to have conversations about advanced care planning. Next slide, please. Becoming a CNS. So recently NHS England has set out the accend programme, which is looking at really transforming the cancer workforce with education, training, learning and development. So there's a pathway for people. Here in the trust, we have competencies for the different bands that can help with career progression. In our role. Next slide, please. I hope that's given you a little bit of a taste of what we do, and I'm happy to answer any questions. Thanks for listening.
Thank you. Has anyone got any questions for us? If you want to just pop your hand up. Shahid.
Hi, thanks both for that presentation. Really insightful and interesting, because it kind of gives that clarity about what kind of journey people go on. I was just wondering about this question of patients who are referred to the London Trust. How do you continue to support that communication? Because I guess that's often one of the big issues that comes up.
Yeah, no, absolutely. So it mainly over the phone. So obviously we're quite familiar with our partner CNSs in the hospitals. So the patients will have access to the CNS in whichever hospital they're referred to as well. But we tend to have quite good links with them. So, you know, they'll let us know if there's been a change in the patient's coming back to us, or if there's a problem. So it's generally over the phone that we provide support for the patient when they're away from us. But that is a challenge of our role.
Thank you. No, that's and you know, we see that in our data a lot, so that's really reassuring to know that there's that connection. Thank you.
We've got a question in the chat from Hannah. What would you say is the most rewarding part of your role?
I think probably what first attracted me to cancer care many moons ago really is I like with cancer care you get a continuity with patients, so you do almost go on their journey with them, and I find that really rewarding. You know, obviously nobody wants to go on that journey, but if I can be there just to help, even with the perhaps smallest of worry, well then I've done a good job. So yeah.
So for me, it was always knowing we could make the difference. I knew I could make a difference to these patients, and actually they're really appreciative.
Yeah, absolutely. And you get to know them over sort of a long period of time usually as well. So
thank you, Hannah. Any other questions? Hattie says, thank you, really helpful to understand the pathway better. Thank you, Hattie. Anyone else, or should we close the webinar? Lisa, what is the most challenging part of your role?
That's a tricky one. Well, we have lots of challenges. You know, obviously, as I said, when things don't necessarily go to plan, it can be quite challenging. Obviously, when patients get a diagnosis, they want things done super quickly. So sometimes it's just about setting expectations and what are realistic time goals. I think one of the challenges we have in colorectal, we don't have any of our surgical clinics on site here at Harlow. So they have to go to Herts and Essex or Epping, and patients sometimes feel a bit, sort of certainly patients that live in Harlow feel a bit upset that they can't come to a clinic actually at Princess Alexandra. So that can be a challenge, and also for us as CNSs, because we are having to sort of travel out, although we sort of make that work as best we can.
Thank you, Lisa.
Question about if somebody
if someone is interested, oh, it's all going a bit quick now. If
someone is interested in
becoming a cancer CNS, who should they contact? Well, they can contact or shadow any of the cancer clinical nurse specialists if they wanted to see what a day in the life of is like. The other thing they could do now is look up the accend programme, ACCEND, which is which is let's tell you what it stands for. It's only just been rolled out. Aspirant Cancer Career and Education Development Programme, and that is based really for nurses, AHPs, other professions, and right through from being a healthcare assistant to registered nurse, right up to sort of AMP level. So there is a sort of the development framework there. So that's worth having a little look at as well in the first instance.
I do that one. Vanessa's asked about, can I explain more about the FIT test? So the FIT test is actually used in the diagnosis process. Often the GP will have done the FIT test when a patient presents to a GP with symptoms, and basically it's a poo test. It's much better than the old test where patients had to put samples on pieces of card. This is just like a little stick that is the patient swipe through their poo. It's very accurate. It looks for blood in the poo, and the measurement helps to give us an indication as the whole diagnosis process.
Thank you.
Oh, that's a good one from Lisa. What helps you cope with your role and promote your...
Hang on.
Oh,
I think Shahid
sorry.
was up there. Shall I do Shahid? So
Yeah.
one other question Shahid has is about the ward level staff how are they educated and supported as they are providing care in a non-specialist setting? Yeah, that's a really good one, Shahid. So ultimately, I don't think there is any specific training for the ward staff. Yes, they might have access to the cancer clinical nurse specialist, but I'm not sure they always know who to access and how to access. We have just developed a web page on AlexNet, so all the tumour sites are on there, all the contacts for all the different CNSs are on there. So that's just been launched this week. In addition to that, I would like to roll out, and it has been part of the actions from the National Cancer Patient Experience Survey, I think with COVID and things and the sort of restrictions on the wards for a long time, nothing followed through. But I think as a minimum, it would be good to do a sort of a quarterly or yearly cancer training day for the non-cancer nurses. And also it would be good to look at rolling out parts of the Accend programme that's just been introduced. So I need to look at how we could implement that and to what level in our trust.
I think I was just going to, I don't know whether it's sort of relevant, but I was going to say, I think Alertive has perhaps aided the wards because they can see who's in the role and send us messages that way. So hopefully that's supporting the ward teams a little bit more as well. Shall I do Lisa's question? That was a good one. Lisa's asked what helps us to cope with our role and promote our own well-being, and that's a really good point. Actually, we are human. We are often touched by different cases and our patients, but we do have the benefit. We all get clinical supervision as CNSs, and that really helps us just to talk about cases perhaps that have been difficult, and just get support from our colleagues. So yeah, that's a really useful function.
Is there any more? Oh, Nia's put the link to our new workspace in the text box, so that's great. Thank you, Nia. And Aquila, are there circumstances where you as CNS had to challenge, question medical decisions taken for patients which were not more holistic and you had to advocate?
Yeah, I would say we do that on a fairly frequent basis, you know, taking a patient's wishes into consideration. Sometimes medical staff get a little bit, you know, making a plan, and actually when you talk to the patient, perhaps they've decided they don't want any treatment. So yeah, we are very used to standing up and saying, no, the patient's decided they don't, or, you know, likewise, sometimes patients are very keen for treatment, but they're clearly not fit, and part of our role can be helping them come to terms with that as well.
Thank you, Aquila. I think that's all the questions. Okay. Thank you. Thank you everyone for joining. We'll draw it to a close if there's nothing more. Thank you.
Thank you.
Thank you very much.
Thank you very much.